Welcome to a new episode of Neomed AI Podcast, the podcast that offers insightful AI for better neonatal care. Today we're tackling neonatal sepsis, a high-stakes condition where subtle signs can mask a life-threatening emergency.
Sepsis is a core challenge in our specialty. Neonates are incredibly vulnerable and can become critically ill very quickly, so a robust framework is essential for their safety.
I couldn't agree more, and that's our goal today. We'll start by building the foundations, using a classic case of early-onset sepsis to explore the pathophysiology and initial steps. Then we'll see that case through to the 36-hour mark, diving into the nuances of management and the crucial principles of antimicrobial stewardship. Finally, we'll move into the grey areas and consultant-level challenges, tackling complex cases, controversies, and future directions. Okay, so let's set the scene with a case. You're the junior doctor on call. You get a call from a midwife on the postnatal ward. She's worried about a baby boy born just 2 hours ago at 38 weeks. The delivery was normal, but she mentions the mother spiked a fever of 38.2 degrees Celsius during labor. The midwife says the baby just isn't right. When you arrive, you see he's working hard to breathe, with a little grunt at the end of each breath. His respiratory rate is fast, up at 70. He's refused his first feed, and when you check his temperature, it's 36.1 degrees Celsius. Let's use this classic and frankly worrying presentation to unpack the fundamentals. For anyone new to this area, could you first expand on that core distinction between early and late onset sepsis?
Of course, it all comes down to the timing and the source of the infection. Early onset neonatal sepsis, or EONS, which is what this case screams of, occurs within the first 72 hours. The infection is acquired vertically from the mother. This can happen in utero if there's an ascending infection or during the passage through the birth canal. Late onset sepsis, or LONS, happens after 72 hours. Here, the pathogens are acquired horizontally from the postnatal environment. Think of contaminated equipment, the hands of carers, or other sources within the neonatal unit, or, less commonly, the community. The distinction is critical because it changes our list of likely suspects and our initial choice of antibiotics.
That makes sense. So, focusing on our 2-hour-old baby, what are those likely suspects for EONS here in the UK?
In the UK, 2 organisms dominate the picture: Group B Streptococcus, or GBS, and Escherichia coli. GBS is a bacteria that commonly and harmlessly lives in the genital tract of many women, but it can cause devastating invasive disease if transmitted to the baby. E. coli is the other major player, a gram-negative rod that can be particularly virulent. We also have to consider Listeria monocytogenes. It's much rarer, but it's a nasty bug that can be acquired from contaminated food products and is classically associated with maternal pyrexia, so it must remain on our differential.
You've described a baby with multiple worrying signs. The NICE NG 195 guideline gives us a framework for this. Can you walk us through how it helps us to structure our thinking?
It helps us structure our thinking by providing a clear, structured method using risk factors and clinical indicators to identify babies at risk of early onset infection. These risk factors include maternal issues such as intrapartum fever above 38 degrees Celsius, prolonged rupture of membranes, and current or previous maternal Group B streptococcal or GBS infection, as well as preterm birth and a specific red flag for suspected infection in a sibling from a multiple pregnancy. The clinical indicators in the baby are also assessed. Our baby shows multiple signs: respiratory distress indicated by grunting and tachypnea, poor feeding, and temperature instability.
So when you see a risk factor like that maternal fever with a collection of these clear clinical signs, is there any room for observation?
Absolutely not. The guidance is unequivocal. The presence of a risk factor with multiple clinical indicators mandates immediate action. There is no wait-and-see period. You make the decision to treat, and the clock starts. The national quality standard is to have IV antibiotics administered within 1 hour of that decision.
That 1 hour target is crucial. Before we give that first dose, what are the absolute cornerstone investigations we need?
Two things are non-negotiable. First, and most importantly, a blood culture. It's the gold standard for diagnosis and is essential for targeting therapy later. Second, a baseline CRP, or creatine reactive protein. This gives you a starting point for an inflammatory marker that you will trend over time. Both should be taken before the first antibiotic goes in.
You mentioned the baby's low temperature of 36.1 degrees Celsius. We often think of fever as the classic sign of infection. Can you explain the pathophysiology of why a baby might become cold instead?
It's a fantastic question and a vital clinical point. A cold septic baby is often a sicker baby than a febrile one. A neonate's thermoregulatory system is immature. Their hypothalamus, which acts as the body's thermostat, isn't fully developed. When faced with a massive inflammatory insult from sepsis, the flood of cytokines can actually disrupt the hypothalamus's function, leading to a failure to regulate temperature. Furthermore, the baby's metabolic reserves are small. The systemic illness consumes a vast amount of energy, leaving little for non-shivering thermogenesis, which is their primary way of generating heat. So hypothermia is a sign of systemic collapse and shock. It is a very serious sign.
So, to summarize, we have a very sick baby. We've decided to treat. We've taken our culture and CRP. What's the standard go-to antibiotic combination for suspected EONs in the UK?
The standard empiric regimen recommended by NICE is intravenous benzylpenicillin and gentamicin. Benzylpenicillin provides excellent cover for GBS and other streptococci, while gentamicin is a powerful aminoglycoside that targets the gram-negative organisms like E. coli.
Got it. Let's progress our case. The infant was transferred to the neonatal unit, started on IV benzylpenicillin and gentamicin. He needed 4 hours of CPAP for his respiratory distress, which then fully resolved. Now we fast forward to the 36-hour mark. He is, for all intents and purposes, a different baby. He's clinically well, pink, alert, feeding eagerly, and his vital signs are all stable. The blood culture has remained negative. We've done a repeat CRP at the 24-hour mark, and the result is now back. It's 8 milligrams per litre. What is the next step?
This is a pivotal moment in the baby's care and a crucial point for antimicrobial stewardship. The baby is clinically well, and the blood culture, our gold standard test, is negative. According to the NICE guideline, the correct and most appropriate action is to stop the antibiotics.
I want to push back on that a little bit because I know it makes people nervous. The CRP has risen from less than 1 to 8. It's not a huge number, but it's a rise. How can we be so confident to stop?
It's a valid concern, and it comes from a good place of wanting to be safe. But we have to interpret the results in context. Firstly, let's talk about the blood culture. The evidence is very strong that more than 95% of clinically significant pathogens causing EONs will be detected by a blood culture within 36 hours and over 99% by 48 hours. So a negative culture at this point is highly reassuring. Secondly, the CRP. A level of 8 milligrams per litre is still very low and has a high negative predictive value for ruling out invasive bacterial infection. CRP is a non-specific inflammatory marker. A difficult birth or transient respiratory problems can cause a minor rise. So, we weigh the very small, almost negligible risk of a missed infection against the very real, proven harms of continuing unnecessary antibiotics.
You mentioned the harms of unnecessary antibiotics. Could you expand on those?
Certainly. We're increasingly aware of these. Firstly, there's the disruption of the infant's developing microbiome. We are carpet bombing their gut with broad-spectrum antibiotics, which has been linked in studies to a higher risk of conditions later in life like necrotizing enterocolitis, allergies, and even autoimmune diseases. Secondly, there are direct drug toxicities. Gentamicin, while highly effective, carries risks of nephrotoxicity and ototoxicity. And thirdly, and this is a huge public health issue, every unnecessary course of antibiotics drives the selection of drug-resistant bacteria on our neonatal units. So adhering to the 36-hour rule in a well baby with negative investigations is a critical stewardship intervention.
That's a very clear rationale. You mentioned gentamicin. Can we briefly touch on how we dose and monitor it safely in UK practice?
Yes, this is bread and butter neonatology. We use an extended interval dosing regimen. For a term infant like this one, it might be a dose of 5 milligrams per kilogram given once every 36 hours. The idea is to give a high peak concentration, which is what gives you effective bacterial killing, followed by a long trough period where the drug level is very low, which minimizes the risk of toxicity to the kidneys and the ears. To ensure safety, we take a pre-dose or trough level before the second dose. We're aiming for a level below 2 milligrams per liter. The BNF for children is our go-to guide for these protocols.
Perfect. Now, this case has focused on eons. Let's pivot to LONs. You mentioned the pathogens and risk factors are different. A common problem with LONs is a blood culture that grows coagulase negative staph, or CONS. How do you distinguish a genuine infection from a simple skin contaminant?
That is a daily challenge on the neonatal unit. CONS are the most common cause of LONs, but also the most common contaminant of blood cultures. Making the call requires putting all the pieces together. A single positive culture in a completely well baby with a normal CRP is almost certainly a contaminant. For a diagnosis of true CONS sepsis, we generally require more robust evidence. This typically means at least 2 separate positive blood cultures drawn from different sites, or 1 positive culture in an infant who is clearly symptomatic, like our complex case we'll discuss later, and has a significantly raised CRP, for example, over 20 milligrams per liter. Getting this right is crucial to avoid treating contamination as sepsis.
This brings us to differences in practice. I've heard more and more about the Kaiser Permanente sepsis risk calculator being adopted in the US. It seems quite different from our NICE checklist.
It's a fundamentally different philosophy. The NICE guideline uses a categorical approach. You have a risk factor, yes or no. You have a clinical sign, yes or no. It's a checklist. The KP sepsis calculator is a multivariate statistical model. It takes the mother's specific risk factors, like her exact temperature and duration of ruptured membranes, and combines that with the infant's objective clinical examination, which is serially monitored, to generate a precise numerical risk of sepsis per 1,000 babies. This score then recommends a course of action, which might be routine care, enhanced observation, or a full septic workup.
What are the pros and cons of that approach for the UK?
The major potential benefit, highlighted by several UK-based studies, is a significant reduction in antibiotic use. Some studies suggest we could reduce the number of babies we treat by up to 50%, which would be a huge win for antimicrobial stewardship. However, the major concern, and the reason it hasn't been adopted by NICE, is safety. The calculator was developed in a US system with a different GBS prevalence and a universal screening program. There are legitimate fears that in our system, the calculator might miss or delay treatment in a small but significant number of septic infants. It remains a key area of debate and research.
Let's escalate the complexity now, moving into those grey areas. Let's introduce a new, much more challenging case. We have an extremely preterm infant, born at 26 weeks gestation. He's now 15 days old. He's been dependent on an indwelling long line for parenteral nutrition. The nurses call you urgently. He's having new onset apneas and bradycardias, looks grey and peripherally shut down, and his temperature is 37.9 degrees Celsius. A blood gas confirms a significant metabolic acidosis. You do a full sepsis screen and start him on IV vancomycin and gentamicin. 20 hours later, the lab calls. The blood culture is positive for gram-positive cocci in clusters. What's running through your mind? What's the pathogen, and what are the absolute priorities here?
This is the call we all dread. In this specific clinical setting, an extremely preterm baby with a long line and septic shock, the combination of gram-positive cocci in clusters makes coagulase-negative staph the #1 suspect. Specifically, we worry about Staphylococcus epidermidis or the increasingly problematic multi-drug-resistant clone of Staphylococcus capitis. The immediate priorities go far beyond just antibiotics. First is aggressive resuscitation, fluid boluses, potentially inotropes to support his blood pressure, and likely intubation and ventilation to manage the apneas and acidosis. The second and equally critical priority is the central line. You must have a very high-level discussion about removing that line as soon as possible. The bug is almost certainly living on that line, protected within a biofilm.
Can you explain what a biofilm is in simple terms and why it makes treatment so difficult?
Imagine the plastic surface of the catheter. The bacteria land on it and start to build a fortress. They excrete a slimy, sugary substance that creates a protective matrix. This is the biofilm. It allows them to hide from the body's immune cells and, crucially, from the antibiotics circulating in the bloodstream. You can be giving maximal doses of vancomycin, but the drug simply can't penetrate this shield effectively to kill the bacteria at their source. That's why in established central line-associated bloodstream infections, or CLABSIs, line removal is often the only definitive cure. Failure to remove it is associated with treatment failure, metastatic infections, and increased mortality.
A really vivid explanation. What about when you see a baby like this, who is so sick, and you're waiting for cultures? When should you start thinking about adding empirical antifungal therapy?
That is an excellent question. Empirical antifungals are reserved for the highest risk infants who are deteriorating despite broad-spectrum antibacterial cover. The key risk factors, all present in a baby like this, are extreme prematurity, especially birth weight under 1,000 grams, the presence of a central line, being on TPN, having received multiple prior courses of antibiotics, and any significant gastrointestinal pathology. If this baby wasn't responding to vancomycin and gentamicin, and we had a high suspicion of fungal sepsis, we would consider starting a drug like liposomal amphotericin B while waiting for cultures.
We've talked about diagnostics. What about newer technologies, like PCR-based tests? Are they changing the game?
Not yet, is the simple answer. PCR tests, which detect bacterial DNA, have the advantage of speed. They can give a result in hours, not days. However, they have significant limitations. They can't distinguish between live and dead bacteria, so they might stay positive long after an infection is treated. They are also prone to detecting contaminant DNA, leading to diagnostic confusion. And most importantly, they don't provide antibiotic sensitivities. So at present, they are a research tool and have not replaced blood culture as the standard of care in routine UK practice.
Finally, on this complex case, let's talk about the future for these survivors. If this baby pulls through, what are the long-term neurodevelopmental risks?
The risks are substantial. A severe episode of sepsis, especially in a preterm infant, is a major insult to the developing brain. The mechanisms are multifactorial. The massive inflammatory response, with cytokines flooding the system, can breach the immature blood-brain barrier and cause direct inflammation in the brain. The septic shock itself, with episodes of hypertension, can lead to perfusion injury and damage to vulnerable white matter. So this infant is at a significantly increased risk of long-term problems, including cerebral palsy, cognitive and learning difficulties, and sensory impairments. Survival is the first battle. Protecting the brain and supporting long-term development is the long war.
Okay, to consolidate all this fantastic information, let's run through a few quick-fire consult scenarios. Are you ready?
Fire away.
First, a term baby is born. Mum was known to be GBS positive, but had a very rapid delivery and received no intrapartum antibiotics. At 1 hour of age, the infant is completely well, pink and vigorous. What's the management?
This is an infant with one risk factor, but no clinical signs of infection. According to NICE, the correct management is a period of enhanced observation in a healthcare setting, usually on the postnatal ward, for at least 12 hours. This involves recording vital signs at set intervals. No antibiotics are immediately indicated.
Perfect. Next case, a 3-day-old term infant who was discharged home presents to the emergency department. The parents are worried he's not himself and hasn't fed for 8 hours. His temperature is 38.5 degrees Celsius.
This is a pediatric emergency. It's suspected community-onset LONS. The priorities are immediate: ABC assessment, secure intravenous access, take a blood culture and baseline CRP, and administer empiric intravenous antibiotics within 1 hour. A lumbar puncture should also be very strongly considered. The antibiotic choice for community-onset LONs is typically cefotaxime with the moxicillin added to cover for listeria as he is under 1 month old.
Excellent. More complex one. A 25-week gestation infant on TPN via a long line has a single blood culture grow Candida albicans at 48 hours. The infant is clinically stable but has a rising CRP.
This is invasive candidiasis, a serious LONS. The optimal management strategy has 3 essential components. 1. Initiate systemic antifungal therapy with liposomal amphotericin B being a common first-line choice. 2. Remove the central venous catheter, as it is the presumed source and nidus of infection. 3. Perform investigations to look for disseminated disease, which must include a renal ultrasound and a formal ophthalmology review to rule out end-organ seeding.
Great. Last one. You're the consultant for the week. The unit has had 2 cases of LONs caused by gentamicin-resistant E. coli in the last few days. Both infants were in the same intensive care bay. What actions do you take?
This is a potential outbreak and requires an immediate, coordinated response. First, declare an outbreak investigation and convene a meeting with the hospital infection control team and microbiology. Second, implement enhanced infection control precautions. Cohort the affected infants and the staff caring for them if possible, and order enhanced environmental cleaning of the bay. Third, send the bacterial isolates for genetic typing to confirm if they are a single clonal strain. Fourth, you must issue a unit-wide alert and critically review the empirical antibiotic policy for LONs. You would likely need to switch from gentamicin to an alternative agent like amikacin, pending further results from the investigation.
That was an absolutely brilliant and comprehensive walkthrough of a complex topic. Thank you so much for sharing your time and expertise.
It was my pleasure. Continuous education on this topic is what keeps babies safe.
If I were to summarize the most vital messages from our discussion, I think they would be, first, time is brain and time is life. In suspected sepsis, especially EONs, that 1-hour target from decision to treatment is not just a guideline, it's a lifeline. Second, stewardship is an active process. Trust the 36-hour rule. In a clinically well infant with reassuring investigations, stopping antibiotics is a safe, evidence-based and crucial decision. And third, when faced with late-onset sepsis in an infant with a central line, you must suspect line infection and plan to remove the line. As a final thought for our listeners, it strikes me that despite our guidelines and evidence, managing neonatal sepsis remains an art as much as a science, a constant balancing act between the aggressive action needed to save the individual and the cautious stewardship needed to protect the many. It's a judgment call we make every single day.
Thanks for listening to Neomed AI Podcast, and join us next time. Just a reminder, this AI-generated information is for educational purposes only and is intended for trained neonatal clinicians. It does not replace independent clinical judgment. Always refer to the current national and local guidelines.